Welcome back to Prime Morning. It's time for Good Living segment right here on Prime Morning. And today we are talking about uterine fibroids, embolization. But we can't talk about, this minimally invasive option for treatment for fibroid without delving a little bit into the tumor fibroid. And so speaking with me on this topic today is Dr. Dorothea Enim, and she is a specialist in radiology. Good morning, Doc.
Good morning, Asidua.
How are you?
I'm good. How about you?
I'm great. So today's topic, uterine fibroid embolization. But before we delve into that, we want viewers to know about fibroid, which is something that a lot of women are dealing with, unfortunately. And so what is fibroid in the first place? All right.
Before we go into what fibroid is, thank you for having me here. Thank you for giving me the opportunity to spread this good news to everyone. You know, sometimes we see good news in the religious term, in terms of salvation. But if I have a message that carries hope, that can even save your sister, your friend, your mother from losing their life, I consider that as good news. Right. So today, I have the opportunity to share this good news, and I'm grateful for that. But back to your question, fibroids are growths. They are benign growths that involve the uterine wall. So the uterus has a wall, and it's a muscular wall. So you get these growths that form at different portions of the muscular wall. It can be close to the inner portion, then it will be given another name. The middle portion will be given another name, and the outer portion. So these fibroids are benign growths that involve the uterine wall.
So what are the names then?
So if you have it close to the inner wall, just under the mucosa, we call them submucosal fibroids. Okay. Then if it's in the muscle layer proper, we call it intramural fibroids. If it's in the subserosal layer, we call it subserosal fibroids. Some can have a little stalk and even protrude outside, then we call them pedunculated fibroids. Okay. It can be within or outside, but basically, depending on where you find them, then we name them.
Okay. Now, what age bracket of women can develop fibroid? Because when you read about it, it says that women, premenopausal women, are more affected with fibroids than women who are younger. And so what is the age bracket for women who can have that tumor?
So fibroids generally would affect women within their reproductive age group. So anywhere from someone starting their menses all the way to the ending their menses, you can have fibroids. So you and I are friends, our peers, we are all at risk of it. And you know, literature even says that Black or people of African descent, we are more at risk than anybody. So if you took 10 people globally from any part of the world, and they were all of African descent, 8 out of 10 will have fibroids. Okay. So it's something that is very peculiar to the Black skin, and that's why it's important we talk about it. Yeah.
Right. Now let's come to the treatment options available for fibroids. What are they?
So there are quite a number of treatment options, but before we get there, let me just touch on the symptoms, because that would reflect on the treatment options. So sometimes the fibroids are there, they are quiet. You have them, they are not causing any problems. So you are okay. Sometimes they cause problems. So then let's talk about some of the problems that they can cause. Their sheer size, because we all know that fibroids grow. As they grow, they tend to compress on structures around, because they grow in the pelvis, which is the lower part of the abdomen. So if they press on the urinary bladder anteriorly, you present with what we call frequency. That is, within a short time, you want to go and urinate. If they press on the rectum posteriorly, you have constipation. So you have women, 3 days, 1 week, they're unable to pass to constipation. Fibroids can do that. If they press on the veins from the legs that drain, it causes pain in the leg, swelling in the leg, the blood stays in the leg, clots can form in the leg. I could go on and on. And then also they affect the menstrual cycle. Heavy menses, prolonged menses, and then frequent menses. You don't have a 28-day cycle anymore. 18 days, you have your menses. Then another one starts. Then sometimes people can even bleed the whole year through because of fibroids. So they cause all these symptoms, and then also issues with fertility. These are what they cause. So the treatment modalities depend on whether one, is it a symptomatic type or it's not. If it's not causing any problem, what we will do is that we call it watchful waiting.
Okay.
We just observe you, follow you up with serial scan because we know they are there, monitor their sizes. If it's growing, then if it starts causing problems, then we intervene. So that's the first group. Now, for those who have symptoms, there are a number of options available for them. Okay. There are the surgical options, and then what we are going to talk about today, the minimally invasive option. So just to touch on the surgical options, so we have myomectomy, which is when the surgeon goes in and takes out the fibroids one after the other. So it's an open surgery. They cut you open, they expose the uterus, and they take out the fibroids one after the other. Then we have hysterectomy as another option. This is when the surgeon goes in and takes out the uterus. Because if you don't have the uterus there, you and I know there'll be no fibroid. Right. So they take out the whole uterus. So even with modern medicine, you find out that now we have minimally invasive ways of trying to even do these things. Yeah. But as we move from that, let's come to the minimally invasive procedure, which is why we are here today. So that is uterine fibroid embolization. Some literature will call it uterine artery embolization. Okay. It's the same thing. It depends on which book you are reading or which school you went to and what they choose to call it. But the technology behind it is that fibroids are fed by blood vessels. In fact, everything in the body is sustained by blood vessels. Okay. And so once we are able to identify the vessel that is feeding the fibroid, and we put in particles or agents, which we call embolic agents, they occlude the blood vessel. Once the fibroid is not being fed, it goes to reason that over time it will shrink and it will die. Okay. So that's the principle behind it. And minimally invasive means that as compared to open surgery, where we'll give you a cut here, a big one, and go in and do that. This one, it's not a cut. There's no suturing at the end of it. It's a nick. We call it a nick. Very tiny, just about 3 or 2 millimeters cut. That's what it is. So at the end of the day, there's even no need for suturing. It's just tiny plaster over there. So that's a bit about what uterine fibroid embolization is. But I'm sure as we discuss, I'll throw more light into the steps. Okay, now you mentioned that, you know, it's not necessarily a suturing or a huge cut that like the one that we are used to. It's just a very small one. Very tiny. So where is that? Take us through the process of how the whole thing is actually done. Okay, yeah. All right. So how we assess the vessel that supplies the fibroid. You know, the body is such a wonderful creation. All the blood vessels in the body are connected. So if I'm heading towards my pelvis to find a fibroid, and I can get into a blood vessel and navigate my way like a map, Google map, from anywhere, I should be able to get there. So we use 2 main routes. We can go in from the wrist. I know the wrist is so far away from the uterus. So far. Yes. But that is how technology has advanced. We can go in from the wrist, a small nick, 2 to 3 millimeters, not even 1 cm, and navigate through the artery that runs over there. It's called the radial artery. And since it's connected, once we have a map, which is the image guided, it means that we have something that allows us to track where we are going. We navigate our way through the whole body, go down all the way to the pelvis, to the vessel that supplies the fibroid, and then we deposit the embolic agents in there. So that's the first access. We can also go in through the groin, same principle, get into a vessel and navigate our way under image guidance to the vessel that supplies the fibroid and deposit the embolic agent in. So what would make you want to go for the wrist and not the groin or other way? So usually we assess the patient. Most patients actually will want the wrist. Why? The reason being that if I go through the wrist, when I'm done, it's just a tiny plaster here. At the end of the day, the same day, the patient picks their bag and they walk home. Nobody knows they've had a fibroid surgery. Just a tiny plaster here. But if I went through the groin, what will happen is that the vessel that I assess in the groin is a bigger vessel. And so they may have to lie down for the next 4 to 6 hours so they don't bleed from the side. And that is a bit limiting for the patient because I keep you for 4 to 6 hours. But compare that to hysterectomy or myomectomy, you'd have stayed in the hospital
longer.
I know, right?
Yeah.
For about a week or so, just before you get to go home. So basically, we assess the patient, we look at the vessels, we see which one is more accessible, and then we decide which one we'll do. But because the wrist is more preferable for most women, it'll be our first option, unless after assessments we find out that maybe we cannot access that vessel very easily. Then we'll opt for the groin.
So mostly where to assess or which parts of either the wrist or the groin, you leave that to the discretion of the patient?
No. We, the doctors, we, the interventional radiologists,
but you end up asking them?
Well, it comes up in the discussion, yes. Because, for instance, my first option for somebody will be that, so I'm going to go through the groin. So when I'm talking to the patient in preparation for the procedure, I'll tell you that I'm going to go through the groin, I'm going to do this and that and that. But if that is not successful, sorry, the wrist, but if that is not successful, I'll go through the groin. So it's part of it. If the wrist is not as accessible, then I'll go through the groin. So I prepare you for both. But because I know that the wrist is more preferable, I'll tell you that first.
Okay. What could make the wrist not accessible?
Some people have very tiny vessels, so maybe the artery there is very small. Or maybe they've had a previous procedure over there that has distorted the anatomy. Maybe there are lots of calcifications with the artery. All those things could make it not accessible. But for most people, it's accessible. So most of the cases that we do, if we were doing 10 cases, 7 of them will be from the wrist, and maybe 3 will end up having the groin. So
can it be on either wrist?
Yes, it can be on either wrist, but because we usually tend to stand on the right side of the patient for these procedures, we usually go through the right wrist because then it's closer to us.
But tell us about the risks involved. Are there any risks involved with this procedure?
All right, so generally, the risks are minimal. That's why it's minimally invasive. And, you know, anything that doesn't open you up very much, anything that doesn't touch a lot of other organs whilst you are trying to fix it is safer. So when you read literature, you read that it is very safe and it's low complication, okay? But some of the things that can happen is that with regards to the procedure itself, I told you that we get into a blood vessel.
A blood vessel,
so anytime you enter a blood vessel, an artery, it means there's a risk of bleeding. So that is a risk that's associated with it. So even when the patients come in and we are talking to them about the procedure, we mention these things to them. But of course, because we all know that that's a risk, we know what to do to prevent it from happening. So it doesn't happen, but it's a risk that's associated with it. Either from the groin, which most of the time the risk is higher because I said the vessel there is bigger, or from the wrist, there's a risk. And anytime you enter into someone's body, whether it is a tiny neck or not, there's a potential that you may introduce an infection into the system because you see that we are entering a blood vessel and they are all connected. So if I introduce an organism into, let's say, your artery, it could go anywhere and cause an infection. So infection is also a risk. But you'd see that these procedures are not done, even though they are done within a short period, you get to go home. We do it in a place, it's known as the angio suite. It's angiography suite or a catheterization lab. It's just like a theater, and everything there is sterile. The patient would change before they come in. We will wash down, we'll wear sterile. Everything is open just for the procedure. So that also takes care of that risk of introducing an infection. All right, the other thing too that's associated with this is that sometimes, depending on the kind of fibroid that the patient has, if it is one of those ones that I said has a stalk, a thin stalk, and it can protrude either into the lumen or outside. We call them the pedunculated fibroid. After the procedure, a few of them will expel the fibroid. It means the stalk will break off and then the fibroid will either be expelled from the cervix out or into the abdominal cavity. That's also a risk, but that's why you come in for assessment, and that's why it's a specialized procedure done by an interventional radiologist. So after you assess, we see all these things and then we negate the risk as much as possible before the procedure is done.
Okay, so after this is done, I mean, how long exactly? You said within a short period, but you went specific as to maybe an hour. So how long does it take for this procedure?
Okay, so you know, everybody's anatomy is different. I said that. So navigating my way through your artery all the way to the the uterine artery, which is actually the vessel that we are targeting here, may be straightforward for one person, may be difficult for another person. Also taking into consideration that maybe the person has a lot of fibroids, big fibroids, which have changed the anatomy of the vessel. It's not clear-cut that you would go straight out. It's just like me coming here. I may meet a lot of traffic one day, for another time it may be straight, within 2 minutes I'm here. So anywhere between 1 hour, 2 hours. For some people, we've gone as far as 3 hours before.
Okay.
Because sometimes it's a bit difficult trying to navigate to identify the vessel and get into it so that you can deposit the embolic agent. But if it is straightforward, within an hour. The other thing too is that everyone has 2 uterine arteries. So we'd go to the right one and put in the agent, embolize it, and then go to the left one and then put in the agent and embolize it. So because we'd have to do 2 sides, that will probably take about maybe an hour on the lower limit, or maybe 2 hours. But in extreme cases, difficult cases, we've gone up to 3 hours before.
Is it expensive?
Well, I would say it's cost effective. That's the first thing I'll say about cost. Because if you have something that is minimally invasive, something that will not keep you in the hospital for a long time, something that will let you go back to your family, let you get back to work, and something that is innovative, then expense really is relative. Because as you can understand, we are talking about it today because many people don't even know about it. Exactly. And so I would say it is cost effective. The actual cost of it, it's even subjective. If you even went to a government hospital for, say, hysterectomy, and you went to a private facility for, say, hysterectomy, the cost may also differ depending on what services is rendered here or here. So in terms of cost, it's subjective, but I'll say it is cost effective.
So after you go through this procedure, there's no way that you could have the fibroids developing again?
So what happens is that when you deposit the embolic agent, I told you that they cause what we call ischemia. So they block the blood supply, and so the fibroid is not being fed.
Right.
So as it's not being fed, if you are not being fed, you grow lean, and then eventually you will die. So it shrinks over time. So over time, we get a reduction in size, And for those people that they were having symptoms because of the size of the fibroids and the location of the fibroids, all those symptoms go away. If you are having heavy bleeding, which can cause anemia, which can even cause heart failure, that will stop. If you are having all those pressure symptoms, that will stop. So the problems that it was causing, all of that will regress, and the fibroid itself will shrink in size. It will not disappear like magic, but it will shrink gradually over time.
Right.
And remember, all the problems are caused by the size. And with this, you still get your uterus in there.
So with this procedure, at what stage is this needed?
So this is needed for anyone who has fibroids that's giving them problems.
Okay.
That's causing any of the things that we discussed. But of course, when you come in, we'll assess you, we'll evaluate you, you do some labs, you do an ultrasound, maybe we'll add an MRI, because we need to be sure that this problem you are having, it is the fibroid that is causing it, and not that something else is causing it and you have fibroids as well, because the treatment is for fibroids. So we'll go through all of that assessment to ascertain that you are a good candidate, and these are some of the things that we do to determine that you're a good candidate. But if you have fibroids and it's giving you problems, and we do imaging and we confirm that your problems are because of the fibroids, you're a good candidate. You're good to go.
Right. Dr. Dorothea, thank you very much. Before you go, your final remarks on this.
Okay, so what I'd like to say is that fibroids are very common for blacks. It's very, very common. And you don't need to suffer in silence. You don't need to carry this burden and not know what to do about it. Interventional radiology has joined the war against uterine fibroids together with the obstetrician and gynecologist to fight it. And this is a minimally invasive approach. You get to go home the same day, faster recovery, it's safe, it's proven and tested. It's been going on for over 25 years. It's just that it's now that we are introduced, even here, for about 3.5 to 4 years, we've been doing it. People don't know. Yes.
Okay.
Yeah. So come see your doctor, talk to your doctor about it. In Ghana, Euracare, Ghana, you can get it done there. Also, Korle-Bu Teaching Hospital, the radiology department, you can also make inquiries there. You can get it done at these two places. Don't suffer in silence. You don't need to. Thank you.
Before you go, would you recommend this over every other treatment option?
Of course I will.
Right, okay. Right, Dr. Dorothea, thank you very much. And so our topic for discussion today on Good Living segment has been uterine fibroid embolization. I hope you've learned a lot. Dr. Dorothea says that she would definitely recommend this over every other treatment option. So if you know you're going through these symptoms of fibroid, visit your doctor as soon as possible and get treated. My guest today has been Dr. Dorothea Enim, specialist radiologist and interventional radiology fellow in training, Ghana College of Physicians and Surgeons. Viewers, that's it for Good Living segment. My name is Asiedua Akumia.